Hello students, welcome to EPG Pathshala. I am Dr. Hardeep Kaur from Ramjas College, University of Delhi. Today we are going to be talking on module Immunodeficiency Part II from paper Immunology. The learning objectives of the module are: what is immunodeficiency? What are immunodeficiency diseases? Mechanism or causes of immunodeficiency diseases? Types of disorders, pathogenesis of the immunodeficiency diseases, and methods of diagnosis and treatment of immunodeficiency diseases. Let us recall. In lecture on Immunodeficiency Part I, we discussed the following: what is immunodeficiency, history of immunodeficiency, classification of immunodeficiency diseases into primary immunodeficiencies and secondary immunodeficiencies. Now, the primary immunodeficiencies, as we had discussed in our previous chapter, have been subdivided into humoral immunodeficiencies, cellular immunodeficiencies, which is the T cell defects, the combined immunodeficiencies, which is B and T cell defects, disorders of complement system, as well as disorders of phagocytosis. Now, if you remember, the first three subtypes of primary immunodeficiencies have been covered in lecture on Immunodeficiency Part I. However, the disorders of complement and disorders of phagocytosis, along with secondary immunodeficiencies, will be covered in this lecture. Now, students, as already discussed, immunodeficiency is the state in which the immune system is incapable to mount a successful immune response against an antigen. Therefore, the body's ability to fight a pathogen is compromised or at times completely absent. The outcome could be variable in severity, with sometimes maybe negligible effects, or at times it could lead to severe systemic manifestations. Generally, immunocompromised individuals have recurrent infections and are also based on the number of components of immune system that are affected. The symptoms of infections could vary largely. It could be very mild or it could be highly systemic and acute infections. The classification of immunodeficiency disorders can be as follows. The immunodeficiency disorders can be divided into primary immunodeficiencies and secondary immunodeficiencies. The primary immunodeficiencies involve abnormal immune system that can involve anomaly in innate or adaptive immune system. The deficiencies could be due to impaired B cell system or impaired T cell system or cells of innate system. The primary immunodeficiencies are further classified as humoral immunodeficiencies, that is B cell defects, cellular immunodeficiencies, that is T cell defects, combined immunodeficiencies, that is B and T cell defects, disorders of complement system, and disorders of phagocytosis. In the previous lecture, that is Immunodeficiency Part I, we discussed the first three types of primary immunodeficiencies, while disorders of complement system and disorders of phagocytosis along with secondary immunodeficiencies would be discussed in the current lecture, that is Part II. Disorders of complement system. Complement is the group of serum proteins that are very important for mounting an effective immune system. The activation of the complement pathway is a very well-regulated mechanism that is effective in destroying the invading microbe with minimum damage to the tissue of the host. The system is also involved in the elimination of unwanted materials such as dying cells or immune complexes and is also responsible for the development of adaptive immune responses. It is a common belief that the impaired complement system is not able to differentiate between normal body tissues and hence in turn also leads to autoimmunity or the dysfunctional complement system. The latter may be involved in partial attack on foreign microbes that leave behind remnants of foreign fragments that are indistinguishable from the host tissues, leading to attack on self cells. Genetic deficiencies involving almost all complement components have been found in humans. Generally, these are inherited as autosomal recessive trait. It has been seen that homozygous deficiencies in components of classical pathway C1q, C1r, C1s, C4 and C2 have almost similar symptoms. An increase in systemic lupus erythematosus, rheumatoid arthritis, vasculitis and glomerulonephritis are commonly associated with the above conditions. There is also a rise in immune complex formation in all these diseases, clearly showing the importance of the early components of classical pathway in activating C3b, which is very important for immune complex clearance. These complexes eventually grow very huge in size, leading to their deposition in tissues and inflammation of the area. Streptococcal and staphylococcal infections are also found to be recurrent in such patients. The deficiency of factor C2 is also a very common form of PID, with frequency of its occurrence as 1 in 10,000 for homozygous deficient patients. About 5 different mutations in C2 gene have been found to be the cause of C2 deficiency. In predominant cases, there is a deletion of 28 nucleotides from C2 gene. Generally found in young adults, it increases their susceptibility to recurrent infections, mostly upper respiratory streptococcal infections. However, the most severe among all is the C3 deficiencies, which may be due to low C3 synthesis or deficiency in factor I or factor H. Decreased concentration of C3b have an adverse effect on the process of opsonization. Alternatively, a specific mutation in C3 gene is also the cause of C3 glomerulopathy, a rare kidney disease that leads to complete shutdown of kidney functions. Deficiency in C4 components also increases the incidence of systemic lupus erythematosus. The defects in the process of opsonization could also be due to deficiency of components of alternative pathway of complement activation. A deficiency in factor B, factor D, or properdin can lead to decreased levels of C3b. The gene for properdin is X-linked. The protein properdin stabilizes C3b-BB or C3 convertase and increases its half-life. Decreased properdin hence adversely affect the process of opsonization, which is largely dependent on C3b. This in turn leads to decreased defense of body against Neisseria infections. The defect in lectin pathway also leads to increased incidence of infection. MBL, that is mannose binding lectin, is an important collectin protein responsible for activation of C4 and C2 complement components. MBL deficiencies hence increase the susceptibility to infection with the yeast Saccharomyces cerevisiae and bacteria such as Neisseria meningitis and Streptococcus pneumoniae. MBL deficiency has actually been found to be both X-linked or autosomal recessive. The deficiency of terminal complement components increases the susceptibility to meningococcal diseases along with Neisseria infections, particularly Neisseria meningitis and Neisseria gonorrhea. The other common complement deficiency diseases include paroxysmal nocturnal hemoglobinuria, that is due to deficiency of complement inhibitors CD55 and CD59. The hereditary angioedema, that is associated with low C1 inhibitor levels, and atypical hemolytic uremic syndrome is due to mutations and polymorphism in complement inhibitors. Lastly, the age-related macular degeneration is because of polymorphisms in complement inhibitor factor. Disorders of phagocytic system. Defects in the lymphoid lineage principally affects the adaptive immune system, while the defects in the myeloid lineage impact the innate immune system. The latter generally manifest as weakened phagocytic activity. Phagocytosis is an important mechanism of the body by which bacteria, parasites, dead host cells, and foreign debris are removed by specialized cells called phagocytes. Impaired phagocytic activity leads to periodic infections. The infections can range from mild skin infections to deadly systemic infections. Some of the important disorders of phagocytic system include chronic granulomatous disease, also called Bridges-Good syndrome, Quay syndrome, or CGD. CGD shows two types of inheritance: common X-linked type found in boys and autosomal recessive type found in girls. The diminished activity of phagocyte lies in the defect in their metabolic processes due to mutation in one of the 5 components of nicotinamide adenine dinucleotide phosphate, that is NADPH oxidase, leading to reduced oxygen consumption, reduced activity of hexose monophosphate pathway, and decreased production of hydrogen peroxide, which is very important for bactericidal activity. The bacteria generally involved in recurrent infection are catalase-positive pyogenic Staphylococcus and coliform. The fungus Aspergillus has also been associated with the disease. The disease is chronic and generally fatal. It is characterized by marked lymphadenopathy, hepatosplenomegaly, septic osteomyelitis, and granulomatous lesions in skin and lymph nodes. The most accurate method of diagnosis is to check the amount of hydrogen peroxide in the cells of the body. Antibiotic treatment, or in severe cases bone marrow transplant, are the methods of treatment for CGD. Nitrobutyrosolium, that is NBT test, is performed, and the leukocytes of patients of CGD fail to reduce NBT during phagocytosis. Reduction in neutrophil count. Neutrophils are the most abundant white blood cells present in the blood. Their deficiency can range from complete absence, that is agranulocytosis, to reduced concentration, that is granulocytopenia or neutropenia. The deficiency could be due to some congenital defects or may be acquired during the lifetime because of some external factors. The genetic defect in the myeloid progenitor stem cell may be the cause of congenital disorder or results in reduced formation of neutrophils. This can cause severe neutropenia in the affected individual. Such individuals suffer recurrent bacterial infections. Transient neutropenia also take place amongst certain bacterial or viral infections like typhoid, tuberculosis, etc. However, the neutrophil count becomes normal once the infection clears. Myeloperoxidase deficiency. This is a rare disease in which the leukocytes have decreased myeloperoxidase activity. Majority of patients do not show much immunodeficiency, however, they may suffer from recurrent candida infections. Sheriock-Higashi syndrome. It is an autosomal recessive disease and is due to a mutation of a lysosomal trafficking regulator protein, which leads to a decrease in phagocytosis. The protein plays a critical role in transport of materials into lysosomes that act as recyclers within the cells. It is characterized by oculocutaneous albinism, that is reduced pigmentation of skin, eyes and hair, photophobia and nystagmus, that is periodic rhythmic movement of eye. Phagocytes in the patients contain giant peroxidase inclusions, which may be due to autophagocytic activity. Patients suffer from severe pyogenic infections. Leukocyte G6PD deficiency. In this case, leukocytes are lacking in glucose 6-phosphate dehydrogenase, hence causing defective hexose monophosphate shunt activity, which is associated with low H2O2 production and inadequate bactericidal activity. Hence, they have impaired phagocytic activity. Although the condition is very similar to CGD, however, NBT test is normal in this case. Jobs syndrome, or autosomal dominant type 1 hyperimmunoglobulin E syndrome, also called ADHIES. The syndrome was first discovered in 1966 and is characterized by elevated IgE levels. Multiple large cold staphylococcal abscesses with pus are present on the skin and in various organs of the patients. This is accompanied with eosinophilia, eczema, and recurrent sinusitis and skin infections. The disease is due to dominant negative mutation in STAT3, which is an important signaling molecule of gene transcription. Recurrent skin and sinopulmonary infections are controlled using antimicrobial drugs. Antifungals are used to treat mucocutaneous candidiasis and onychomycosis. Intravenous immunoglobulin, that is IVIG therapy, is also useful in some cases. Job syndrome was named after the biblical character Job. This is a very interesting fact. Job is the protagonist in the book of Job in Bible, whose body was covered with skin sores and pustules by Satan. He is a good and prosperous man, but to test his faithfulness, God asked Satan to subject him to acute sufferings. Everything that was dear to him was taken away. But amidst all his suffering, Job never blamed God, and eventually God has to end his suffering and made him happy and prosperous once again. As was true for Job, in this syndrome, the patient's body is covered with boils. Now, the disorders of phagocytic system, the first disorder is tuftsins deficiency. The deficiency of a small peptide, that is tuftsin, that stimulate phagocytosis is the cause of this disease. Tuftstin, it's very interesting to know, it was discovered at Tufts University, Boston. It's a tetrapeptide. It's made up of threonine, lysine, progene and arginine. And its deficiency leads to local and systemic bacterial infections. This peptide is predominantly made in spleen. Certain situations like splenectomy or myelocytic leukemia are hence accompanied with acquired tuftsin deficiency. The congenital familial deficiency of tuftsin has also been reported. Leukocyte adhesion deficiency or LAD. Certain cell surface adhesion molecules belonging to the family of integrin proteins help in cell-cell interactions. Three of these, namely LFA1, MAC1 and GP150/95, have a common B chain and are present in all B cells. In LAD, there is a defect in the expression of beta chain, hence leading to impaired expression of the three adhesion molecules. This further affects the adhesion of leukocyte to endothelium and hence limits their migration to the site of inflammation. Such individuals show high susceptibility to gram-positive, gram-negative bacterial as well as fungal infections. These infections are generally life-threatening. Lazy leukocyte syndrome or neutrophils paralysis. In this case, there is normal number of neutrophils, but their migration from bone marrow to peripheral blood is highly impaired. This leads to peripheral neutropenia. Patients show increased susceptibility to bacterial infections along with pharyngitis, stomatitis, otitis, gingivitis, and cellulitis. Hyper-IgE syndrome or autosomal recessive type 2 hyperimmunoglobulin E syndrome, also called AR-HIES. In this case, the serum IgE levels are more than 10 times the normal level. The cause behind type 2 HIES is the deletion in the DOCK8 gene. The symptoms also include eczema, eosinophilia, recurrent lung and staphylococcal infections, especially Staphylococcus aureus and Staphylococcus pyogenes infections. These patients also suffer from severe viral infections due to herpes simplex, herpes zoster and molluscum contagiosum. Most of the patients of AR-HIES are from families where consanguinity is involved, that is intermarriage among close relatives. Schwarzman disease or Schwarzman-Diamond syndrome. In this disease, several parts of the body get affected, particularly bone marrow, pancreas, and the skeleton system. It is a rare genetic disorder characterized by pancreatic exocrine insufficiency and improper functioning of bone marrow. This hence leads to insufficient circulating blood cells. Low neutrophil counts along with their decreased mobility leaves the patient susceptible to recurrent infections. Skeletal abnormalities along with slow growth are also key features of the syndrome. Schwarzman disease is characterized by an autosomal recessive mode of inheritance. The gene that is mutative in this syndrome, that is SPDS, lies on the long arm of chromosome 7. SPDS stands for Schwarzman-Bodian-Diamond syndrome. The pancreatic exocrine insufficiency is generally overcome by pancreatic enzyme supplementation, while skeletal abnormalities might require surgical intervention. Bone marrow transplant may be the final resort in many cases. Secondary immunodeficiency diseases. Secondary immunodeficiency diseases are those that occur due to certain environmental factors. These are generally acquired during the lifespan and are much more common than the primary immunodeficiencies. The secondary immunodeficiency disorders can be further characterized as the secondary immunodeficiency disease can be divided into acquired hypogammaglobulinemia or agent-induced immunodeficiency. Further, the agent-induced immunodeficiency could be due to the drugs, due to certain other factors, or it could be due to certain biological agents also. Acquired hypogammaglobulinemia. The immunodeficiency can manifest itself at any age depending on the underlying cause. Patient is prone to recurrent infections. The level of immunoglobulin is found to be very low. The function and number of T cells may be normal in this case. The cause of acquired hypogammaglobulinemia is not very well understood. The gamma globulin treatment is the preferred line of treatment in this case. Agent-induced immunodeficiency. A variety of external agents or factors may cause a deficit in the immune state of an organism. These can be chemical or biological agents like cytotoxic drugs, or maybe certain infections agents like HIV-1, which is human immunodeficiency virus 1, or it could be due to any other factor like malnutrition, malignancy, obesity, etc. Immunodeficiency due to drugs. Corticosteroids. Corticosteroids are generally used to combat autoimmune diseases like rheumatoid arthritis or SLE, that is systemic lupus erythematosus, and they induce an immunodeficient state in the treated patient by inducing lymphocytopenia and lymphocyte death. Corticosteroids also have a detrimental effect on cytokine synthesis and T cell activation. Cyclosporine A or CYA. It is a powerful immunosuppressant that is used to prevent organ rejection. It inhibits the production of cytokines that are involved in the regulation of T cell activation. Cyclosporine A binds to immunophilins that also play a very important role in signal transduction. Methotrexate or MTX, also called amethopterin. It is a chemotherapeutic agent and immunosuppressant. It is used to treat cancer, ectopic pregnancy, and autoimmune diseases. Methotrexate is also a folic acid analog and hence can block folic acid dependent DNA synthesis pathways. Its prolonged use also leads to reduction in immunoglobulin synthesis. Immunodeficiency due to other factors. Exposure to certain factors as given below could also cause a state of acquired immunodeficiency. These factors include radiation therapy given to treat various forms of cancer, severe burns, obesity, aging, prolonged sickness, malnutrition, exposure to environmental toxins like mercury, heavy metals, pesticides, etc., cancer of the bone marrow and of blood cells, also called leukemia or lymphoma, etc., hormonal and metabolic disorders like anemia, hypothyroidism, diabetes, hypoglycemia, etc. Smoking, drug abuse, and alcoholism also leads to suppression of immune system. Immunodeficiency due to biological agents. Over the last few decades, all other immunodeficiency diseases have been overshadowed by the secondary immunodeficiencies caused by retrovirus, human immunodeficiency virus 1, that is HIV-1. The presence of the virus has led to an almost epidemic of a disease called acquired immunodeficiency syndrome, that is AIDS. The virus is predominantly present in the body fluids of an infected person, could be blood, semen, vaginal fluid or breast milk, and can be passed from one person to another through sexual contact or blood-blood transfusion. Additionally, virus can also be passed from pregnant mother to fetus during gestation or during childbirth. Due to the gravity of this disease, the efforts of creating an effective vaccine to combat AIDS are still going on. The 1st December is considered as the World's AIDS Day since 1988. The characteristic feature of the syndrome is the complete loss of CD4 positive T helper cells, followed by acute immunodeficiency, making people vulnerable to other diseases. There is generally a nexus between AIDS and other opportunistic infections like tuberculosis, pneumonia, candidiasis, hepatitis, and meningitis, eventually leading to death within 10 years of infection. Prognosis and prevention of immunodeficiency diseases. The most important ways how you can prognose or to prevent these immunodeficiency disease is the early detection. Knowledge of family history, that is, you can go in for genetic counseling in prospective patients or prospective parents, or promotion of practicing safe sex. Delay in diagnosis can lead to complication and sometimes death in the patients. Good food with high nutritional value can curb the occurrence of malnutrition-induced deficiency diseases. Some diagnostic tests are levels of blood complement which can be tested. The blood or urine electrophoresis can be done to measure antibody levels as well as their types. We can go in for checking immunoglobulin levels. Testing for HIV can be made mandatory. White cell count and neutrophil function assays can be done. Cytokine assay following stimulation can also be performed. Lymphocyte count and proliferation assays can also be done. Treatment of immunodeficiency diseases. The immunodeficient person must avoid contact with another person suffering from an infectious or any communicable disease. So prevention is always better. All kinds of bacterial and fungal infections must be treated at the earliest. An infection must be treated with aggressive antibiotic or antifungal treatment and for a longer duration than in case of the normal disease or infection. Prophylactic treatment may also be given. Patients suffering from AIDS are given combination of drugs to prevent viral load. Passive immunizations with preformed immunoglobulins are also effective in most cases. Bone marrow transplant is the last resort in most of the immunodeficiency diseases. Of course, eating right, being physically active, getting adequate sleep, and managing stress are very, very important things which can prevent immunodeficiency diseases. So students, let us now summarize what we have learnt in this module. Immune system of our body is the most effective system that detects and eliminates foreign antigens like bacteria, viruses, parasites, etc. However, immunodeficiency disorders abate this tendency of our immune system. An immunocompromised individual is particularly vulnerable to opportunistic infections. Although many of the primary immunodeficiency disorders have a genetic basis are hence not preventable, the occurrence of secondary immunodeficiencies can however be restricted. World Health Organization, as we call WHO, has recognized more than 300 different primary immunodeficiency diseases. The secondary immunodeficiency disorders are more common among critically ill, older or hospitalized individuals, hence making them more prevalent than primary disorders. Effective treatment of the infections and boosting the immune system can be the most important measures that can be taken to overcome these diseases. Thank you.